Sorry about that. There's a call that interrupted. So our dear guests on the call, the experts on Ebola fight in the country, Dr. Annette Alenyo and your team, Dr. Amos, the health workers that have logged in, other members of the community, fellow doctors, you're all most welcome to this webinar on Ebola awareness for our region. And I would like to extend my deepest appreciation to all of you for taking time to join this very crucial Ebola awareness webinar. And your presence on this call is very vital because it will help us highlight and to help us also share and resolve and also make recommitment to safeguard the people that we serve within the affected areas across our country. I also want to, as you all know, we are now facing a serious public health epidemic in the name of Ebola, hemorrhagic fever in our country. And we appreciate Ministry of Health and the World Health Organization for championing the fight against this epidemic. And also we appreciate our frontline workers, Dr. Annette and the team, for making it important that we have such a webinar to build awareness in our community. With the confirmed cases that we've reported so far in and around the major hubs in our country, Kampala, Wakiso, it is very vital that we do not panic, but rather we take swift, informed action. And no one is safe until everyone is safe in our country at the moment. So the importance of this webinar this evening is that a disease does not respect border, especially the Ebola epidemic does not respect borders. As we know, it originated from Congo. And the panic around Ebola is often born out of ignorance of the community and even ourselves as health workers. But we know this virus. We've heard about it before. We know what it has done to our country and our region. And we even know how to stop it. So this webinar is basically designed to help build our capacity this evening so we are able to make informed decisions and health choices to protect our community. I am very confident that the guest speakers on this call, Dr. Annette and Dr. Amos, will be able to cover the most vital things, if not everything, from how the virus spreads and then how it manifests in form of disease. So with this knowledge, we hope we will be able to empower our fellow health workers and also empower the community in which we live. So I therefore call upon each and every one of us logged on the call to listen attentively, ask all the questions that you have to ask. We have experts on the call who will be able to respond and help build our capacity even better to empower the people that we serve within the community of Greater Nebi and Uganda at large. So with this said, I welcome you all to this webinar. We look forward to great learning and experience sharing. Thank you very much. Over to you, Chair.
Thank you very much, Dr. the President of Greater Nebi Health Link, for the laboratory remark. Participants on the call, as already alluded to, the Ebola situation currently in the country, we are well aware over 10 cases have been registered with both imported and local transmission taking place within, I must say, within the West Nile sub-region, maybe greater region. Particularly, we do not have case as of today, and that does not mean we are at risk. The country has flagged us on high alert, looking at the proximity with our neighboring DRC border, and also the population dynamic that the people span through Greater Nebi to DRC, and these are the same people. So it creates for us the need for having this webinar today, looking at expanding the role of communities and also the roles of the healthcare workers. The aspect of community surveillance and the roles of the healthcare workers is what we'll be discussing in this particular case. And I'm glad to introduce to you our two facilitators of today, none other than Dr. Annette Alenyo, who is a seasoned doctor with about 20 years of experience, about 15 of which in the area of emergency medical services, and also looking at care in disaster situations. With the vast experience and has facilitated conferences locally and internationally, we'll be glad to hear from you, Doctor. And after her, we shall have the next facilitator, none other than Dr. Amos Nyapirombo, who, with over 30 years of experience in areas of community health, with experience in managing plague situation in the Greater Nebi in the past. These are the facilitators we'll be having on our call today. We are glad to receive you, and we call upon your audience, and when the time for the question and answer comes, you'll be able to participate fully on that. With this, allow me call upon the one sharing the slide, Dr. Pius. Please get the slide up as I take the due honor to welcome our first facilitator, Dr. Annette. Thank you so much.
Thank you very much, moderator and DHO. I am glad to be on this call. Dr. Pius, is it okay if I share my slides on my site so that I can move them at my speed?
I think that is fine. Dr. Pius, you can unshare, then we reshare. Thank you.
Right. Just give me a moment to do that. Dr. Pius, if you could stop sharing. Thank you. All right, I hope you can all see my screen.
Doctor, the screen is clear.
Yes, we can.
Proceed.
Perfect. It's an absolute pleasure to be on this call. As a daughter of Nebi, I was very anxious when I saw that area categorized as a very high-risk area. And I think, I thank the team from Greater Nebi, the executive, for organizing this webinar. It's a wonderful and timely webinar. So my presentation is going to cover two large sections. One is Ebola, really. What is it? The second part of the presentation is what do I do? I won't share my video because I know that we are all struggling with bandwidth, but I will show you my face at the end. I know there are people who always want to see the presenter's face. So we'll start with what is it? What is this Ebola? And in answering what is Ebola, the first thing for us to understand is where are we with Ebola? Ministry of Health yesterday, Tuesday, 2nd of June, the country has 15 confirmed cases. 12 admitted, 2 are discharges, and one passed away. On the left of my screen, if you look, you will see that map of our beautiful country with a number of districts with that bold maroon color, and the category says very high risk. If you see the entire West Nile and all the districts are along the over 700-kilometer border of Uganda with the Democratic Republic of Congo, is marked as high maroon, meaning very high risk. Risk management, you know, there are a lot of things to consider, but more importantly is the risk of being exposed to whatever threat it is. And for us, the threat is Ebola. We know that in DRC, there are over 100 cases, there are nearly 1,000 contacts. So people who have had, who have been in touch with Ebola patients and therefore at risk of getting the disease and spreading it further. So they have, and as the DHO said, we've had imported cases coming in from the DRC, which puts us at risk. So the risk of being exposed, but also risk considers our preparedness, our readiness as a team, and the capacity of our system to mitigate that threat so that the impact is very, very minimal. So what we are trying to do now is to improve our knowledge, our skills, and our readiness to make sure that should we face the threat as health workers within this maroon area, the zone that we are in Greater Nebi, we are better prepared, and therefore the impact of Ebola in our community will be lower than if we had not been prepared. Ebola is considered a VHF, a viral hemorrhagic fever, and there are so many families of viral hemorrhagic fevers. And since I'm speaking to scientists, and I do know that there are a number of people on the call who are not health workers, I will try to speak in a language that you can also understand, because I know there are people who have joined as a matter of curiosity. So there are various families of viral hemorrhagic fevers, Bunya viride, Arena viride, very interesting names. For Ebola, it falls under the family Filoviridae. There are other viruses like Marburg virus in the same family. The non-reservoir for this is the bat, and usually it is around Central and East Africa, which is where we fall. So Ebola was first identified in 1976. Ebola was in DRC in 1976, but at the same time, that same year, there was another outbreak of Ebola, Sudan type in Sudan. So there was the one in Zaire and the one in Sudan in the same year. And that is where it was first identified in the world. And it was named after a river in that geographical area where that first outbreak was, Ebola River. Majority of us on this phone call were not yet born by that time. But during our lifetime, we are still responding to the same issue. And it is still wreaking a lot of havoc. The havoc it does, originally, there's a very interesting book I once read called Ebola that even talks about the West African Ebolas. Previously, Ebola it would happen in rural areas, small places. It comes in, an unknown disease, kills people, and then somehow it disappears, mostly within Central Africa. But the day the world really paid attention to Ebola was the 2 years between 2014 and 2016. In those 2 years, between the countries of Guinea, Sierra Leone, and Liberia, the world witnessed the largest and worst outbreak. Nearly 30,000 people, over 11,000 people died, many of them health workers. That is the time the world actually appreciated that Ebola can wreak such havoc. It would clear families in some places. You find one survivor, some places, families were completely eradicated. Communities were really affected. Other more recent outbreaks, DRC, of course, they had one even just last year, 2018, 22, 2022 years, then 2021, 2025. So you see a pattern of about 2 to 3 years you're having Ebola. Uganda, most of us will remember the 2025 last year, Mbale, Kampala, Fort Portal, 2022 in Mubende, and that more central region of the country. But we've also had others. And if you know the history of Ebola in Uganda, these outbreaks often, there's a different strain. So we've had Zaire, we've had Sudan. Now we've had Bundibujo. This is the second time we've had it. So previously, everyone thought, actually in the last response, when I was in Mbale, and we were trying to set up an Ebola treatment unit, we set up one in the middle of the city. And one of the responders came to me and said, Dr. Lenyo, you cannot do this. I said, do what? You cannot set up an Ebola treatment unit in the middle of a city. I said, why? And he said, well, Ebola is a disease which is managed deep in rural places where you can't even access with a car. Why don't you take the treatment unit there deep, far, somewhere in the bushes and manage those patients from there? But what Ebola has shown us is that there is a shift from all those rural cases to now more urban places. And the public health principle is to manage at source. So now we are seeing Ebola in cities like Kampala, where it is scary. Mbale in the middle of the city. So it's no longer a disease of very far villages and remote places. It has become even an urban problem. So this slide really just shows you the historical timeline of not only Ebola, but also Marburg. And you can see Ebola started in 1976. Marburg was first identified in Germany almost 10 years earlier, 1967. If you look at the pattern, there's always some 2 to 3 years, especially for Uganda, we have one, and other parts of the world. But if you look at all these, majority of it is within Central and Eastern Africa, and of course, the devastating West African outbreak. The reservoirs, largely bats, and that is the current known reservoir. The case fatality is really how many people die out of those that are infected. And it can go up to 90% for Ebola Zaire. The transmission for Ebola is really zoonosis. So a zoonosis is a disease. So animals are animals. They have their diseases, and all of us know animals. We keep animals, chicken, birds, apes, etc. Now, animals have their diseases, which attack them and affect them. Even we humans, we have our diseases, which affect us and don't necessarily affect animals. Okay? But there are some diseases which can cross from an animal to a human being and cause disease. Some of them can cross, but they won't make you sick. Some of them cross and make you sick. Now, Ebola can cross from an animal to a human being and make the human being sick. But not only does it stop there, some diseases stop there. Whoever, maybe a hunter killed an animal, gets the disease, and it will only kill that hunter. It moves from that human, from the animal to the human. Ebola can now spread from that human to another human, which is a problem. Okay, so it not only moves from animal to human, but now you have human to human transmission, which is possible, which becomes a big problem. Down there, you can see the different types of Ebola viruses. Zaire, Bundibujo, which is what we have now. Sudan, which we had in our previous 2 outbreaks. There's Reston, there's the Thai forest, and there's the Bombali. So these are the different types of Ebola viruses. Our focus for this particular outbreak is Ebola Bundibujo. So how does it move? I've told you from animals. So there are animals, for example, it moves from the bat to the apes because they stay in caves, maybe they have exposure, and then it may move straight from the bat to a human being because the human being went to dig for gold in a cave, etc., whatever humans will do in a cave. And then from the animal, it goes to the human being. Either you handled an infected or dead animal that died from Ebola, or direct contact with an infected bat, which is rare. And if you look in history, a lot of these, some of them have even been hypotheses, unproven things. Now, from the animal to the human is called a primary human transmission. Then you have the secondary human transmission, where it goes human to human. Oftentimes, the people who are at high risk of this usually will be wherever this sick person has sought help. So let's imagine someone is exposed somewhere in a bush or wherever, comes back home, starts falling sick. The immediate family at risk because they are taking care of him. So oftentimes when there's an Ebola patient, the children, the spouse, especially the spouse, will likely be infected. So someone who has had direct contact with this person when they start giving secretions, blood, vaginal fluid, seminal fluid, etc., any fluid from that person. All right. So primary caretakers, health workers, people come, they're aerating, you clean, cleaners, okay, in health facilities. Sometimes the thing with Ebola, it may not heal immediately. So you will find someone hopping from clinic to clinic, like we saw classically in the Mubende response. Someone goes to this clinic, they are not healed. They move to another clinic, they are not healed. So they hope eventually they will also reach a traditional healer, Ibanga Joga. So they'll reach Ibanga Joga, and then their Joga is also affected. So these are also all people who are at risk, okay? But even after recovery, when we test your blood and say it's not there, it persists in certain fluids, significantly semen for men. So you will find that even after discharge, protected sex is encouraged, but also in the survivors clinic, we do routine seminal analysis. And there have been reported outbreaks from survivors of Ebola who have gone on in the community post-discharge, had sexual intercourse, and the virus that is still alive in the semen, it's not there in the blood, it is alive in the semen, causes another infection from viral persistence. So we've gone through the transmission. I don't need to repeat this, but perhaps to highlight that direct contact and the body fluid, just think of any body fluid from the person, saliva, vomit, urine, feces, breast milk, sweat, semen, anything, okay, with an infected or a dead person. I will pause for effect because we have been seeing very heartbreaking videos where communities have attacked the safe and dignified burial teams and touched the face of the dead person. Yes, there is culture, and I know Dr. Amos will speak to the cultural issues, but a deceased person is also highly infectious, especially when they've just died. The viral load is so high. The virus is at its most aggressive. It has multiplied to its maximum. And when you touch at that point, the chances of getting infected are really almost 100%. Mothers can transmit to their children during pregnancy, birth, or breastfeeding. And so apart from the direct human contact, there is what we call indirect contact, and contaminated object, maybe the bedding, needles, equipment that you've used on the patient, clothing, etc. And health workers, this is where the 5 moments of hand hygiene are very important. And one of them is after touching the environment of a patient, you must wash your hands. And this is the reason, because of the indirect contact. Someone leaves Ebola on a table, you sit on it, or you touch your face, it goes in. Okay, so all of these. Then traditional burial practices, especially that involve handling of the dead body, are a driver of transmission. I will give an example. In the Mobende outbreak, there was a family whose, and I know many of you read about this or saw it on TV or saw it in the newspaper, one of their family members died. The burial was conducted safely by the safe and dignified burial teams, those people who come wearing those PPEs. They buried and they left, and the community was cancelled. When they left, the community felt that the body had not been treated right to their best. The burial had not gone to the way they wanted, and therefore they exhumed the body, even after being guided against that, performed their body washing, and it was a Muslim family, so there are rituals about cleaning the body well before the body is buried. And within days, they all started dying. One family. So all the people who were involved in that STB, almost all of them were died. Okay, I will pause for this flyer. I'll post all of them on the chat. And you can have them access to them, but I know the DHO has them, and his office should be able to distribute. This is really a summary of what I have said regarding transmission. This is also still transmission, but to highlight, within healthcare settings, health workers are at very high risk during patient care, but the risk increases when you have close contact without PPE. So strict IPC is essential whenever you manage any patient. None of us would want to manage a patient. Then you go home and the DHO calls you and says, Kedwogi, the patient you managed has tested positive for Ebola. You touched with your hands, you touched the bed, you touched the patient, examined freely without wearing gloves, you didn't wash your hands, the patient coughs, you intubated the patient, you did CPR on the patient, there was blood everywhere, you did not wear a visor, etc. I'll give you a good example. In our last outbreak, the one that was January last year, 2025, there were health workers exposed in Mulago, in the ICU. I think you all know that. But these people were followed up and they did not test positive because when they were intubating that patient, they were wearing PPE and they washed their hands after. It really protected them, even when they didn't know it was an Ebola patient. So no matter what is going on, please use PPE for all your patient encounters. Funeral practices, traditional barriers. Often in our culture, we have direct contact with the body. But in the event of an Ebola outbreak, let us open our ears and listen to what we are being told, because the body remains infectious after death. Okay, so safe barrier practices are critical. Let us work together and say, listen, we need to touch, because in our culture, we must do this. How can we safely ensure our person has been touched the way we want them to? What can we do away with? What must we do? How can we modify this? And that is why the barrier is done by a safe and dignified barrier team in a way that is safe but culturally appropriate or acceptable. So when are people infectious really? If I touch a patient now, I touch the vomit or the blood and then I go home, am I infectious? No, I'm not infectious. I become infectious, contagious, when I start manifesting symptoms. When the virus now starts telling me, I am here, I am giving you headache, I'm making you vomit, I'm making you sweat, I'm giving, I'm making you bleed, I'm making you body pain, etc. When the symptoms begin, now you can transmit, okay? And the person remains as infectious as long as there's virus in their body fluids, okay? So the first to clear is in blood. And even when patients are admitted, you have to keep testing the blood, and you test titers and see the clearance rate out of the blood. Once it clears from blood, you can go home, but it remains in the semen. And the reason why we can't take even up to more than 6 months, even a year, for this to clear. We cannot admit you for 6 months, okay? So you are discharged with a specific package, a discharge package, and with persist health education and regular follow-up to test, for example, the semen specifically that has been scientifically proven, and to make sure when it's cleared, you are notified. The biggest people at risk in Ebola are, of course, people who are hunters, these people who are in there looking for these animals that are infected, who get in touch with them, family members and caregivers of people who are infected, health workers, and that is why we've called this webinar Health Workers, okay? Especially without proper PPE. If you have the appropriate PPE, you're not at risk. If you don't have PPE or you don't have the right PPE, you're at risk. Lab personnel handling specimen, people involved in barrier practices, traditional healers, a jogger, and the like. When people go there, they don't have PPE, people sit, they touch, they rub, etc. How long does the virus stay in the body before it starts telling you I'm here? Before it tells you, it makes you symptomatic. So it's 2 to 21 days, but on average, it's about 7 to 10 days. By around day 7 to day 10, so that's about a week and a half, people will become symptomatic, okay? By day 14, most people are symptomatic, but there have been extreme cases. And so the range is 2 to 21 days. But on average, we know between day 7, day 10, latest day 14, most people are symptomatic. These are the incubation periods you can look at later when we share the slides. The stages of infection, same. And this follows many diseases, even many viruses particularly. You're infected, so the virus moves from someone who has it to you, okay? Remember, people who don't have symptoms cannot spread Ebola. Ebola is spread by people who are symptomatic, okay? Between day 2 to 21, you will also get symptoms if you're infected. Average 7 to 10 days. When you start symptoms, we now say, okay, day 0 of symptoms. Then we track you. Early stage, day 0, from when you start symptoms up to about a week. Then we have the spike. This is where it becomes really aggressive, okay? Early stage, it's just body pain, some fever, muscle pain, headache, Day 7 to day 14, that is when we have aggressive disease. It's overwhelming, your organs are failing, etc., as I'll show you in subsequent slides. And then from day 14 to 28 and above, generally people now go into remission. They start recovering slowly up to discharge. Okay, so early phase, okay, non-specific fever, I can't taste, anorexia, body, I'm feeling unwell, I can't eat, my body's hurting, some headache. The problem, if you look at this and our disease profile in Uganda and most of our African countries, this can be any disease, even malaria can start like this. That is why later when I talk about screening and triage, you need to open eyes and ears. Then from the non-specific, you go largely into the gastrointestinal phase, okay, where you have abdominal GI symptoms, nausea, vomiting, abdominal pain, diarrhea. This is now when people say a wet phase. Earlier, you're dry, there's no diarrhea or vomiting. Then you go into that wetness. Some people manifest rash. Bleeding may happen, may not happen, but bleeding usually is yes, hemorrhagic fever, yes, is about bleeding, but many patients actually don't manifest bleeding, or they manifest minimal bleeding, but some may actually have a quite copious bleeding. In the peak phase, that is when your organs feel it. You can get kidney failure, you can get respiratory failure, shortness of breath, people can't breathe, the SATs are going down, neurological manifestations, they are confused, etc., loss of consciousness, heart failure, myocarditis, pericarditis. As you know, with viruses, it goes and attacks anything and everything. If you recover, this is when many people die. If you recover from this, and that can go from like a week to about week 3, okay? If you recover from this, then you're discharged. What we found in people who are discharged, a good number of them actually have uveitis. So they have eye complaints, some inflammatory processes going on in the eye. Some of them post-discharge in their, in the survivors clinic, they still present with joint pain or body pain that has persisted. That takes months to clear and sometimes may actually never go for some of these people, but they will not have died. The diagnosis is one. The gold standard is PCR. Okay, so you just test your blood and do PCR. There have been extreme situations, extreme like in the West African, where the system is so overwhelmed that people start introducing, rapid screening just to help to manage the system, as we did during Ebola. We reached a point where there were even home kits, etc. So you may have some situations, but those are at extreme system extremis. When the system is really in extremis, is really, well, that's when you may hear of such things. But what we are doing in Uganda, current goal is the gold standard, PCR testing. Again, I'll pause for this. What are presented to you, the signs and symptoms, etc. Chair, if I reach more than 30 minutes, please let me know at my 30-minute mark. I think, we started at 10 past. I'm actually at 30 minutes mark. I'll try to wrap up in the next 10 minutes. Now, what happens then is for us to actually fight this disease properly, okay? We have to have everyone helping. You have to guide people. Ebola is not in the hospital. It starts in the community. Health workers are not in the community. In the community, we have community members. So we need the community members to know, this may be Ebola, or I need to report this. Now, we have VHTs, but we have normal people in the homes, and we have the home doctors, the primary health caregivers, the mothers at home, sisters. They need to understand these things because they're the ones who primarily will stay in the hospital with people who will bring the patient, etc. Now, there is what is then called a community case definition to guide the community to report, okay? Now, in the community, if there is any illness in the community, we encourage the community members that if you see anyone who is sick with fever, or not responding to treatment, and at least has the following signs. So fever with any bleeding or any sudden death, and they had fever, bring. Okay? So what we want is to cast a wide net in the community. You bring these people or report these deaths or bring these deaths. But when they come now to the health facility, then we apply another layer of sieving. Okay? So the community case definition casts a wide net because they are not health workers. As we want those fevers, those confusing deaths, they need to report them. These people who are moving clinic to clinic, oh, waterukai, give me malaria, get treating, ujaratuo, gine, jaratuo fodi tuo bemedere. Those are the ones we want. Tuo maube medere nugi, tuo mube keyungo. Those ones we want the community to bring. Okay, that is the community case definition. Now, when they come to the health facility with your screening tool, and I will post it on the group, on the chat, you are going to define what is a suspect. Okay, and the suspect, you will read this in the interest of time. Okay, but any onset with fever or negative lab diagnosis for the usual things, you've tested malaria, you've even treated malaria, nothing. But at least has any of three of the following: headache, vomiting, these are the symptoms we mentioned, okay? Or an illness with an onset of fever, no response to treatment for usual causes, and at least one of the following signs you can see: any bleeding. If there's fever and bleeding, that one really is even most likely towards that phase when they're really very sick. Suspect case, any person with history of fever, at least any of the following: contact. A contact is such an important statement. If someone tells you, someone I know died from Ebola, or someone I know died from an illness we never tested, but they just died after fever, those are very what? High-risk suspects. History of travel to an area with a confirmed outbreak of Ebola. And this is where we come in. People are going to tell you, I've come from Congo. Please, clerk your patients in such a way that they don't fear to give you this history, because it will save them. Okay? It will also save you. So, travel to an area with a confirmed outbreak of Ebola, we know that it's there in Congo. And now even us in Uganda, if someone goes to Denmark now, they'll say, are you from Uganda and you have fever? They become a suspect, okay? Unexplained death, unexplained bleeding. A probable case, someone who died, okay? And we think for many reasons that they likely had Ebola, but were unable to test them. Either way, high-risk contact, they attended a burial, they are a relative of someone, etc. A confirmed case has only one meaning, that they have a positive test. Caring for patients, I'm going to browse over this. It is really supportive care. Ebola Bundibujo has no licensed therapeutics yet, no vaccine. There are candidate therapies, I think as from last week, that the WHO and teams are looking at, MBP 134. And this is what has also been tried for Sudan virus. We used it in the last response of Sudan in last year, Jan, and also used remdesivir. But I know they're also the same drugs are candidates for Bundibujo. Zaire has a vaccine. Some of you on this call may have even got it. Aggressive therapy, early admission, rehydrate, manage symptoms as they appear. We finished one part in 30 minutes. So what do I do? What do you do, health workers on the call? There are general strategies for controlling Ebola. They rotate around 4 key things: behavioral and social interventions, and I'm looking forward to Dr. Amos's presentation. Managing logistics, PPEs, etc., operations, feeding teams, etc., moving teams from one place to another, that is important. Surveillance, actively finding cases, following up contacts, transporting laboratory, transporting specimens, etc. Vaccination, if applicable. It's not applicable for this strain, so we're not doing it. Clinical case management, screen, triage, treat, safe IPC, clinical trials to make sure we get some new drugs. In the middle of all this is a team coordinating. I've highlighted media in red because the media can make or break you. Things circulating on social media should be taken and read with a mature mind. So what do we do? What is our role, health workers? Our role is to identify, isolate, and notify. Okay? Who is a suspect? We isolate them and we notify the right people to move them to the next level of care. Standard precautions, please. If you can take one message from this webinar, is IPC and Ebola as a health worker. Wear your IPC. All right. There are standard precautions, standard things you must do. Hand hygiene, wash hands, wash hands, wash hands. Wear PPE, okay? Injection safety, waste, excuse me, safe waste management, proper environment cleaning, respiratory hygiene, risk assessment. Then there's transmission based. This protects you. The transmission for Ebola is contact. So make sure that your contact precautions are in place. I will move quickly through this because I'm sure you will have a training specifically on IPC. IPC is not just about PPE. It has administrative controls, changing how people work, engineering, using barriers, spaces, creating those triage, those screening 10 places with a meter distance minimum, etc. That is all IPC. Finding alternative ways of care, eliminating, physically removing the hazard, etc. So all this is IPC. It's not just about PPE. Screen, isolate, notify. Do not forget that. What is screening? Observe patient, non-contact. Please don't touch contact. This picture was taken during COVID, so it is not appropriate for Ebola. I'll show you what is appropriate for Ebola. Investigate this patient with a screening tool. The outcome here is, are they a suspect or not? Okay. If they are, you move them to an isolated area, or your isolation or your holding area, pending transfer. Then you triage, see how sick they are. Triage is about seeing how sick someone is so that you determine, are they really too sick, I need to manage now, or are they okay-ish, mild, they can wait. Isolation, separation from others. Separate this patient so that you create a barrier and you cannot continue spreading. All right, so this is the standard one for Ebola, the setup, okay? More than a meter, the patient is on one side, patient zone, which is red. The staff is in the green zone and they dress for the green zone. Here they can wear a gown, a screen, etc. And there should be adequate waiting space, provide a dedicated toilet for this patient, no other patients use it. Patient zone, considered it a red zone. When you're going in there, you wear a full PPE, okay? Now, this I'll skip through. It's really what I've said. This is the PPE for the screening. Because you're not in contact with the patient, you can dress like this. But should you move to the patient area, you have to wear the coverall and the full PPE. Isolation area supplies this. The DHO can guide you as they're setting up, etc. But you need things for patients, for patient care, cleaning, and waste management. This is what you wear in the patient area. So compare it to this in the screening area where you have no contact with the patient, to this where you have contact with the patient in an active isolation place. This is what you wear. Please, hand hygiene, hand hygiene, hand hygiene. There are 5 moments there which you know. I will post these. Hand rub, hand wash, preferably with soap and water. Now, this thing, people are spraying Ebola like they spray their tomatoes in the garden. We don't do that anymore. There's so many issues, okay? It has caused adverse events for health workers. People even say you may skip if the spray misses a corner, etc. Now we wipe, okay? Instead of spraying with chlorine, remove what can be removed, wash, soak, then we wipe, all right? With the appropriate 70% alcohol and chlorine. This is what I've said. Put properly on table. Screen. Do not touch. Stay at least 2 meters from the patient. So create this barrier. 1 meter this side, 1 meter this side. At least 2 meters from the patient. Take temperature. Anyone entering a health facility now, any health facility within Greater Nebi, within the West Nile, or within that entire stretch of Maroon, must be screened. Avoid contact. Isolate them to avoid contact. Explain to family. Transfer the patient to an isolation area. Raise an alert, 6767, or call the number I'll show you. Minimal care. Don't be aggressive. Don't do CPR on these patients. If a patient has reached a stage of CPR, you're not going to save that patient. You cancel the patient, make them comfortable, cancel the family. Transfer to ETU with an ambulance, clean and dispose waste. In-hospital surveillance, please keep an eye on patients who are in hospital. Some of them may have slipped through screening and they will manifest in the hospital. So if you find a patient in the hospital, don't say this one is already admitted. Ebola patients are only walking in. No, you may have admitted, or someone could have admitted a patient and the manifestation starts on ward. So keep your eyes alert and do screening for your patients also. So have it at the back of your mind, even as you see patients. Health workers, if you're exposed, there's a tool to assess your exposure risk and and support you, really. Please be open, because the earlier you report yourself, the earlier you will get help. We lost a health worker in Mubende. By the time we were notified of that health worker, he had wet symptoms. He was vomiting and diarrheating profusely. He unfortunately died. You remember the ambulance nurse that died. So early reporting will save you. Don't fear, don't be ashamed, don't fear, report. This is take home. You can take a picture of this. Take home measures. I told you if there's one thing you take from here, it's IPC as a health worker. Key resources, I'll post this link, but again, you'll have the slides. I'll post this link. It has all the IPC resources. You can look through all these things and inform yourself and do even CMEs within your facility. These are Ministry of Health resources and job aids that you can use. I'll post the link so you can use it. And this is the last slide. I encourage you to take a picture of this, circulate it on WhatsApp. Again, I'll post it on the slide. Call 0800 1066, SMS 6767, log into the website, whatever means. Call the DHO if you forget any of this. I'll take questions, I'm sure, after. Chair, apologies, I've taken too much time. Back to you, DHO.
Yeah, thank you so much, Doctor, for the elaborate presentation. It was to the point we could not interrupt. You have used 40 minutes, which I think is quite okay. Before we go into the next session of question and answer, allow me to take this opportunity to welcome the second presenter for today's. That is none other than Dr. Amos Nathirambo. Doctor, you are most welcome. We have currently up to 125 persons on the call that are participating in today's session. Doctor, you're most welcome.
Thank you.
I'll give you 15 minutes. Thank you.
Thank you, Chair. I hope the 15 minutes will make me do something.
Yeah, we can start and see.
Yes. So can I share my slide?
Yeah, Doctor, your slide is already on.
Is it on? Oh, sorry.
It's already on. You can proceed.
Fine.
Thank you.
Yeah, we are going to thank you, Annette, so much for your presentation. We are going to see now the challenges and maybe breakthrough. And we are looking at the cultural perspective of these challenges and barriers. Annette mentioned some of them. Go to the next slide. My presentation will be informed mainly from my experience. Go up a bit, my experience over the years, working with the community as the district control focal person for AIDS control program in NEBI, then in the 90s, and malaria control focal person, same district, and also the experience we had with the plague epidemic in Okoro, in Zombo district, in the current Zombo district. Then also the experience with the community, which I had when I was a member of the National Trachoma Control Task Force. And also my experience as a lecturer at Makerere and Gulu universities. And my participation in community-based clinical research in the Ituri province of the DRC since 2008 to date, and also as a community eye health practitioner in Uganda and Ituri in the DRC. Finally, as a traditionalist, currently the Minister of Health for Alur Kingdom. As an overview, we all know that an epidemic was declared by the WHO and Democratic Republic of Congo and Uganda on the 15th of May, with the thousands of suspected cases. And in Uganda to date, we have 15 confirmed cases.
Doctor, we seems to be losing you.
Maybe I change position a bit.
Yeah, There now is very
better?
fine. You can hear. Yes,
Clear?
it's better. Yes, please.
Okay, fine. It's better?
Yes, we are good to go. We can hear you loud and clear.
Okay. Then I'm going to give the cultural perspective, especially the challenges. And it gave you quite a lot about what you can do. If we look at the community we are talking about, the diseases are not in the hospitals, they're in the communities. Alur Kingdom, like many other ethnic groups in West Nile and Western Uganda, which are the danger areas, have very close cultural links across the border, both in Uganda and Congo, and also economic links. And two, we should appreciate that traditional institutions have unique, have a privilege of having uniqueness of reaching rural communities, where actually formal health messages and at times even government directives often fail. So we can have all the knowledge, we can have all the expertise, but we shall not be able to reach the community we want to serve. In the control strategies, we use biomedical interventions and behavioral interventions. Majorly, Annette covered biomedical interventions and behavioral interventions by the health workers. But we are leaving the component of the community. So culture is actually a key factor that makes or breaks any response in the behavioral part of the control. And when we look in the African context, cultural settings, in the cultural settings, ill health is not just a matter of health. It's closely interlinked with the spiritual beliefs and practices. Any cause of ill health, of death, are deeply questioned and analyzed critically. And for us health workers or responders to such situations, emergencies, we must have a very deep understanding of the culture of the people we are going to deal with. Now, what are the areas of friction? Between culture and our responses. People who like movies have been seeing. There's a movie in they talk of when East meets West. That's exactly. We are talking about our practices, medical practices, but it's going to meet a conflict of culture. Now let's, Annette ably pointed out, we have a body of an Ebola victim is very infectious. But we also have our culture. What are our final practices? Then two, she talked about Uganda. But I'm now looking at our communities, the Alur. There's a map which doesn't appear in this, which I wanted to show you, but it's okay. All of us know. When we are from Lake Albert up to Sudan border, we have the Alur, we have the Kebu, we have the Lendu, we have the Lubara, we have the Madi, we have the Kakwa. I must tell you that the majority of these populations live on the Congo side. So when we're talking about Uganda, or the Alur community, or the Lugara community, or the Kakwa community, we are simply in Uganda, if we're talking about when we were talking about Congo, it's like getting a balloon. One half you paint red, the other one you paint blue. But when you puncture that balloon, there's no blue color, there's no red color. Simply deflates. And that's what happens. My network is breaking. Are you getting me?
Yeah, but your voice keeps going down and up, down and up.
Please alert me, because it could be a problem with the network.
It is clear on my side, yeah. Maybe others.
Or
It's a
your
roaming network
network.
from Congo. Roaming network from Congo to Uganda.
Okay. Now, when we look at the Alur people, they live on both sides. The Lugbaras, they live on both sides. Actually, over 2/3 of the Alurs and Lugbaras, over half stay in Congo. But we live as one community. And when someone dies, funerals are non-negotiable. People attend, even if it means crossing these borders informally or through illegal means, or even at night. People will go because they have one home here and the other home is there. Rituals. In African culture, you can't even discuss how someone is going to be buried. People have specific roles. The women have to take care of the dead. They have to sit. There is what they call kwirutipu. They have to stay in the houses, and you can't chase them. They will remove their clothes and remain naked for you. Or they even call you a witch. You will be the first person to be targeted, to be targeted. They will say you are the one who killed this person. Now, what are the challenges? We have to do something. They lead to border closures. No contact. Like Annette said, no contact with the dead. But we have grown up knowing that the dead must be treated in such a way. You cannot just come in one day and say, don't touch the dead. And these directives clash directly with this duty of the women who have to sit for 3 days, even after burial. That give a kwiru tipu. And these restrictive measures will make people to hide travel history. They will not tell you as a health worker. They will sneak. My colleagues in Congo are telling me that people are transporting bodies from the epicenter in Mongwalo up to Mahagi, up to Aru, on motorcycles. Now, when they cross into Uganda, they cross to the same communities. Because if someone in Zeu says, oh, I've seen somebody has passed, but they need, you know, that ritual of the belief in Alur that we have to return the bone of the dead to the ancestral place. They will follow that to the dot. Can we proceed? Next slide. Pious. Pious. Next slide.
It's frozen a bit. Let me do some.
Okay, we can proceed as is prepared. Yes, now we have these orthodox versus traditional systems of management. We are rooted in beliefs that we must do traditional healing and cleansing. I did a research on community eye health practices, traditional eye health practices in Nebi. Up to 50%, even with simple eye problems or even complicated, over 50%, up to 50%, first go and treat traditionally with herbs, including us, medical workers. During the day, we are in clinical courts. At night, we are in the shrines. Now, with the high case fatalities due to these epidemics, communities see the health teams as taking people just to die. Because once you go with Ebola or you go with the plague, they say now they have come to take us to go and die. Then some people say hospitals are interested in body parts or are deliberately killing people. Now, what is the challenge? Families will consult the traditional healers because once someone, and that's what is causing us a problem now. Because people, once they believe this is poison, and most of these epidemics, they like this one, which is now happening in Mungwalo, those are business people. They have business rivalries. And at the beginning, people were simply thinking that these are deaths due to business rivalry. And they are highly placed in societies. Why they say that? Once they say that, the commoners will believe. My experience when we were in a pair with Dr. Sam in the 1990s, during the plague control program, people from Uganda strongly believed that it was witchcraft. When our team went to spray these houses along the border, they simply locked their houses and crossed to the Congo side, and we could do nothing. And they were there now mocking the team which had gone to spray the house because someone has said the government wants to make us sterile. So what can you do? They have run away to Congo.
Yes, doctor, you could summarize. Thank you.
Yes.
How many minutes more?
Okay, give me 5. Then we have, but these are very important because we are going to fail if we don't get this. We have communal living. The Alur homesteads are often extended families and compounds. Some extend across the borders. Most social activities are done together, including feeding. Sick relatives have to be cared for at home with very many people involved. And the risks and challenges are given that. So when there is a single disease, single person is a cluster. Then the language. Next slide. Language and trust gaps. Most of these messages are coming to us from the Ministry of Health and imposed on us. Yet our languages, I'm happy this time, these messages are translated in the different local languages.